I'm Mohit Yadav. Can I know your name?
My name is Yadav.
Okay. Do you have any pain in your body?
No, no.
Okay. So today we have examination of your musculoskeletal.
Okay.
Okay.
First inspection. Inspection the shoulder and shoulder girdle anteriorly, then scapulae and related muscles posteriorly. Note any swelling, deformity, muscles atrophy or fasciculation. Now palpation begin by palpating the bony counters and structures of the shoulder, then palpate any area of pain. Begin medially of the sternoclavicular joint, then from behind palpate the acromion, then carotid process, greater tubercle, bicipital groove and tendon, and at last subacromial subdeltoid bursa. Now we will examine the range of motion. First flexion, where patient raises his arm in front and overhead. Extension, where he moves his arms behind. Abduction raises his arms out to side and overhead. Adduction, crossing an arm in front of his body. Internal rotation, placing a hand behind his back to touch his shoulder blade. External rotation, rotating an arm toward the ceiling from shoulder level. Adduct the patient's arm across the chest. Ask the patient to touch the opposite scapula. If the patient touches the scapula from upward side, it tests the abduction and external rotation. If the patient touches the scapula from the lower side, it tests the adduction and internal rotation. Press on the scapula to prevent scapular motion with one hand and raise the patient's arm with the other. This compresses the greater tuberosity of the humerus against the acromion. Flex the patient's shoulder and elbow to 90 degree with the palm facing down, then with one hand on the forearm and one on the arm. Rotate the arm internally. This compresses the tuberosity against the supraspinous tendon and carpocacromial ligament. Ask the patient to fully abduct the arm to shoulder level up to 90 degree and lower it slowly. Note the abduction above the shoulder level from 90 degree to 120 degree reflects the action of deltoid muscle. Elevate the arm to 90 degree and interiorly rotate the arm with the thumbs pointing down as if imitating a cane. Ask the patient to resist as per place downward pressure on the arms. First inspection. Inspect the position of the hand in motion for smooth natural movement. When the fingers are relaxed, they should be slightly flexed. The fingernail ends should be in parallel. Inspect palmar and dorsal surface of the wrist and hand carefully for swelling over the joint or signs of trauma. Note any deformities of the wrist, hand or finger bones as well as angulation. Observe the counter of the palm, namely thinner and hypothinner remnants. Note any thickening of the flexor tendon or flexor contraculars in the fingers. Now palpate first the wrist joint, then palpate the anatomic snub box. Palpate the metacarpopharyngeal joints, then distal interpharyngeal joint, where you may find Herndon joint nodes, and proximal interpharyngeal joint, where you may find Burkhardt nodes, which are common findings in osteoarthritis. Now we'll examine the wrist range of motion. First, for flexion, patient instructions should be with palm down, point your finger toward the floor. For extension, patient instructions should be with palm down, point your fingers towards the ceiling. For adduction, which is also called radial deviation, the patient instructions should be with palms down, bring your fingers towards the midline. For abduction or ulnar deviation, patient instructions should be with palms down, bring your fingers away from the midline. Test hand grip strength by asking patient to grasp your finger, which is second and third fingers. This test function of wrist joint, the finger flexor, and intrinsic muscles and joints of the hand. To test thumb function, ask the patient to grasp the thumb against the palm and then move the wrist toward the midline in ulnar deviation. Ask the patient to place the fingers and thumb in the natural position with the palm up them. Have the patient move the thumb anteriorly away from the palm to assess the abduction. Tenal test. To test tenal, sign by tapping lightly over the course of the median nerve in the carpal tunnel. Test phalanx, sign by asking the patient to press the back of both hands together to form right angle. This maneuvers compress the median. With the patient supine and with the knees in flexion. Inspect the knees, noting their alignment and any deformities. Note loss of normal hollows around the patella or atrophy of the quadriceps muscles. Next palpation, ask the patient to sit on the edge of the examining table with knees in flexion. In this position, bony landmarks are more visible and muscle tendons and ligaments are more relaxed. Making them easier to palpate. For palpating the tibiofemoral joint, face the knee of the patient, place your thumb in the soft tissue depression on either side of patellar tendon. Identify the groove of the tibiofemoral joint. Note that the inferior pole of the patella lies at the tibiofemoral joint line. To palpate the medial and lateral menisci, press on the medial soft tissue depression along the upper edge of the tibial plaque with the tibial slightly internally rotate. Place the knee in slightly flexion and palpate lateral meniscus along the lateral joint line. For palpating the patellofemoral compartment, locate the patella and trace the particular tendon distally until they palpate the tibial tuberosity. Ask the patient to extend the knee to make sure the particular tendon is intact. Now for palpating the suprapatellar pouch. Start 10 cm above the superior border of the patella, well above the pouch, and feel the soft tissues between your thumb and fingers. Move your hand distally in progressive steps, trying to identify the pouch. Continue your palpation along the sides of the patella. Not any tenderness or increased warmth. Check 3 other bushes for swelling. Palpate the prepatellar bush. Palpate over the encina bursa on the posterior medial side of knee between the MCL and the tendon inserting on the medial tibial and plateau. To examine the knee range of motion, first flexion. The patient instructions should be bend or flex your knee or square down to the floor. For extension, the patient instructions should be straighten your leg or after square down to the floor, stand up. Internal rotation, the patient instructions should be while sitting swing your lower leg toward the midline. For external rotation, the patient instructions should be while sitting swing your leg away from the midline. For external rotation, the patient instructions should be while sitting, swing your leg away from the midline. Bulge sign. With the knee extend, place the left hand and above the knee and apply pressure on the suprapatellar post spacing or milking fluid downward. Stroke downward on the medial aspect of the knee and apply pressure to force fluid into the lateral area. Tap the knee just behind the lateral margin of the patella with the right hand. Balloon sign. Place the thumb and index finger of your right hand on each side of the patella. With the left hand compress the suprapatellar pouch against the femur. Palpate for the fluid injected or ballooning into the space next to the patella under your right thumb and index finger. To assess large effusion, you can also compress the suprapatellar pouch and ballot or push the patella sharply against the femur. Watch for fluid returning the suprapatellar pouch. With patient supine, grab the heel and flex the knee. Cup your other hand over the knee point with fingers and thumb along the medial joint line. From the heel, externally rotate the lower leg, then push on the lateral side to apply a valgus stress on the medial side of the joint. At the same time, slowly extend the lower leg in external rotation, the same manual with internal rotation of the foot stress the lateral meniscus. Abduction stress test. With the patient supine and the knee slightly flexed, move the thigh above 30 degrees laterally. To the side of the table, place one hand against the lateral knee to stabilize the femur and the other hand around the medial ankle. Push medially against the knee and pull laterally at the ankle to open the knee joint on the medial. Adduction stress test. With the thigh and knee in the same position, change your position so that you can place one hand against the medial surface of the knee and the other around the lateral ankle. Push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. Anterior drawer sign. With the patient supine, hips flexed and knees flexed to 90 degree and feet flat on the table, cup your hands around the knee with the thumbs on the medial and lateral joint line and the fingers on the medial and lateral insertion of the hamstrings. Draw the tibia forward and observe it slides forward from under the femur. Compare the degree of forward movement with that of the opposite knee. Lekman test. Place the knee in 50 degree of flexion and external rotation. Grasp the distal femur on the lateral side with one hand and other proximal tibia on the medial side with the other. With the thumb of the tibial hand on the joint line, simultaneously pull the tibia forward and the femur back. Estimate the degree of forward extension. Posterior drawer sign. Position the patient and place your hands in the position described for anterior drawer test. Push the tibia posteriorly and observe the degree of backward movement in the femur.